Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast. Ozcast. Simply head to ozcastnetwork.com for details.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, in the running notes for this episode, you said we're talking about FH. What does FH mean or stand for?
So, familial hypercholesterolaemia, FH. So, for yourself, it's much easier to say FH. As I'm trying to get my children to say FH, and it takes a long time. Look, it's a genetic condition, and it's a genetic condition that raises people's cholesterol to points that is, unfortunately, for some people, life-threatening. And it's a condition that's unfortunately under-recognized. And it's about trying to get a little bit of awareness about that in the community.
And we have a number of speakers to join us on this episode, so let's turn to our first one right now. Our first guest on this episode is Dr. Gavin Brown, who completed his PhD in Church History at the University of Melbourne and a Master's in Theology at Yarra, and now lectures in Sacramental Theology and Liturgical History. He's a member of the Department of Christian Thought and History at Yarra Theological Union, a Catholic college that belongs to the University of Divinity in Australia. He also teaches religious education at a Catholic girls' school in Melbourne. But today, he's here as the brother of co-host Dr. Travis Brown. Dr. Gavin Brown, welcome to This Medical Life.
Thank you, Steve.
We have some serious questions to ask, but first, I will tell you, Travis said, I'll introduce him as Dr. Gavin Brown, but he's not a real doctor.
Well, you see, Steve, that's an ongoing dispute. I often say that really when you consider the PhD, we got there first. He came later. Although very quickly, I think by the end of the 14th century, they were calling medical practitioners doctors. But doctor, you know, the word comes from the Latin docere, which means to teach. So it's originally for those teaching theology, but, you know, matters of the soul. And then we included matters of the body later with the medical practitioners. So yes, he's a doctor, I'm a doctor, but I got there first.
Oh, if it weren't for COVID, I'd love to be at the family Christmas gathering every year. But you're here due to the familial connection too. So, Travis, why have you asked Gavin here?
So the reason is Gavin's, well, honestly, the reason why we found out we had familial hypercholesterolemia in our family. It was an event. How old were you, Gavin, when all of this went down?
So at the time I was 43. Not really old enough in most people's minds to be thinking about life-threatening coronary conditions, but 43, and at the time in pretty good health. I was regularly going to the gym, eating well, doing all the right things. I didn't drink alcohol. I don't smoke. Not really a candidate for a heart attack, but life happens.
Can you tell us about the night of the heart attack? Where were you? What was going on?
Yeah, I actually have really vivid memories of things leading up to the attack itself. I'd gone out with my partner to a Malaysian restaurant and had Malaysian food. So no dispersions on Malaysian food. But afterwards, I felt just a little bit funny. Something not quite right. And I was actually starting to think maybe there's a little bit of food poisoning happening here. It just so happened my partner needed some medication and it was starting to get around about, 10-ish. Normal places weren't open. I said, look, I do know of a pharmacy in Paran here in Melbourne. So it was about 20 minutes drive. Between the restaurant and arriving at the pharmacy in my car, getting out of the car, I noticed extreme breathlessness. I mean, very unusual. It was like I'd just run a marathon. And so I started walking. And as it happened, I said, look, I need to sit down. And we were right across the road from the pharmacy. So on the other side of the road was a pub, and it had a seat in front of it. And I used to live in this part of Melbourne many years ago, so I knew this pub. And this was a Saturday night at around about late evening. So I got across the road, sat on the chair, and I just started keeling over. I could feel that I had no energy, I had no breath. And then I said, let's get into the pharmacy. So we walked across the road, and I sort of staggered and fell on the road. Looking back on it later, I can only imagine what people around me in cars and pedestrians were thinking. It looked like I'm probably the local drunk that rolled out of the hotel. But we got into the pharmacy, and I felt at that point this thumping on my chest, like someone was punching my chest repeatedly. At that point, I didn't think heart attack, because that was the furthest thing from my mind. It was just this intense chest pain. I was in a pharmacy, so that was a good place to be. They got onto the ambulance. They put an aspirin under my tongue. So they did the right things. But the ambulance came, and I remember I was conscious. So, it was a heart attack, not cardiac arrest. So I was conscious the whole time. And I could sort of hear them sort of talking among themselves and actually asking, just check if this is a heart attack. And they quickly determined that it was. So at that place, you're about 5 minutes drive from the Alfred Hospital here in Melbourne. So they got me in the ambulance. They gave me morphine. And at that point, I don't remember a whole lot, probably until the angiogram, I'd say.
Mm. Wow. What
a good place to have a heart attack. If you're going to have a heart attack, a chemist. I can recommend a chemist as a place to have a heart attack.
I know Travis has a serious follow-up question, but I've got to ask, if you were a medical doctor instead of a theological doctor, would you have diagnosed yourself more correctly?
Probably not.
Probably not.
No.
Because we don't expect it, do we?
No. And at the age of 43, you said there, just going, gee, this is very unusual. But it was strange. Can you? Sorry, Gavin, you were going to say?
I was just going to say, we knew in our family history that there were some coronary issues on my mum's side of the family. So, people had issues, but in their 60s and 70s, in those years, not at 43.
Mm. Yeah. Can you tell us what you remember about the angiogram?
Yeah, I do remember the angiogram very distinctly. Interesting procedure. I was lying there, and the cardiologist said, look, you're probably going to need some stents. And he explained what that was. But he said, we need to see what's going on in the heart and the vessels around the heart. So I'm lying there. He starts the procedure. And at one point, when the dye moves through, and I could see that he was looking at the screen, and he said, "Oh God." Now, I hope he was having a religious epiphany at that moment, but unfortunately he was not. And he said to me, "Gavin, are you awake?" And I said, "Yes." He said, "I'm sorry, but you have 3 major blockages in your heart. There's no point in doing any stents. We're going to need to do bypass surgery." So, I can't remember what I was thinking at that moment. I was just lying there trying to take that in, because you're thinking about the immediate circumstances. A few hours ago, I was at a Malaysian restaurant.
Yes.
And now I was lying on this bed, being told you need to have cardiac bypass surgery. It was surreal. So, the shock of it really was very apparent. But this was to move very quickly, because they said to me, this is quite urgent. On the Sunday, it would be a case of just making a decision. I was told that they were making a decision around whether I should have the surgery pretty much as soon as possible, which would have been the Monday morning, or whether they wait. The words used to me, I remember very distinctly that one of the chaps said to me, your heart is a little bit mushy at this point. I thought that was probably a word you learn at medical school, but a diagnosis. But they were trying to explain to me, obviously, that the heart was weakened because of the heart attack, but the urgency of the situation meant that they would go for surgery sooner rather than later. So it was the Monday morning at the Alfred Hospital, and I think I was the first cap off the rank. I do remember Travis telling me something subsequently. I think he said, because there's a heliopad there at the emergency centre at the Alfred, and Travis said he, in the morning, as before surgery, he was listening out for the sound of helicopters because a very serious sort of trauma accident or something might have bumped me a little bit down the list, but nevertheless, I was in. I think as early as they would have got me.
So you're not remembering much about all of sort of that time, see, because we were watching. We actually hadn't met Gavin's partner, so the first phone call that we got was about 2 or 3 o'clock in the morning from a partner we didn't know, saying, "Oh, your brother or your son has had a massive heart attack. Mum and Dad were down in Geelong, so it's an hour drive away, and I happened to live near the Alfred Hospital, and he's in having an angiogram." And it's like, again, really unusual. And so I went to hospital, talked to Mum and Dad. Mum and Dad said, "Should we come?" I'm like, "Well, there's almost nothing you can do. Don't come." Now, they ignored me, but that's, normal. And I went and saw. And so while Gavin says I can't remember much from Saturday to Monday, I sort of was studying at the time as well. And what happened was I would go and see Gavin's results. Just as I say, with, ask Gavin's permission. He was off in fairyland, so he always gave it. But you would go and look. And I remember seeing some of the results come through, and things like troponin went up to 40 or 50,000, which I hadn't seen that high before at that time. I'm going, this is pretty serious. What Gavin's talking about is the discussion between a cardiologist and the cardiothoracic registrar at the time. And so they're saying that you see the advocacy happening, and the cardiologist is like, we need to get him operated on. The cardiothoracic saying, we need to make sure he can survive the operation as well. And so you're seeing the subtle politics, and I know those discussions. You see it when you're in the hospital all the time. And what ended up happening was, yes, Gavin was put, again, an emergency situation. He's young, he's healthy, he'll, be able to manage. And so this is all happening. And yes, it was very fortunate, and he was first cab off the rank, but they ended up doing bypass times 6.
That's right.
Yeah. Yes. And the other thing is to have it in front of the Alfred Hospital with some of the most amazing cardiothoracic surgeons. It was just a phenomenal coincidence.
Are you saying there was a divine hand at play? Is that what you're trying to say, Travis?
Well, I might say that.
Well, Gavin might say. The interesting thing is, a week earlier, Gavin had been trekking through Cradle Mountain in Hobart. Yeah. And so if that had happened then, there would have been, no chance.
It was funny, actually, because we were, sorry to correct my esteemed brother, it wasn't Cradle Mountain, it was Freycinet National Park, and we were climbing up a mountain, and I was with a group of people, and I remember being a little bit annoyed because this group of people hadn't been to this mountain before, hadn't been around this area, hadn't been to Tasmania, so every couple of minutes they stopped on the mountain, pulled out the phone to take pictures. And I remember, they're just not serious, they're just, and this annoyed me because it happened all the way up the mountain. But of course, I realized later on, one can't know for sure, but that may have saved my life. Yes. I was getting a rest all the way up the mountain when, of course, as Travis said, if the heart attack had struck then, I wouldn't be here.
Yes.
So effectively what you're saying is something like social media saved your life.
Yeah, in some sort of strange sense, fate was working that way.
Now,
so It's amazing. And I still, we took pictures, and I have pictures of that time. And, I look at those pictures now with that thought that, my goodness, a week later, a tsunami was coming my way. It's unbelievable.
Now, can I ask how you recovered? Because not only did you only have to have, first of all, the heart attack, then a very large operation. Then not only once you recovered physically, you had to sort of recover emotionally. How did you find that process?
The recovery for me was very difficult. I think I've discovered that my body doesn't react very well with very strong medication. So I have quite severe nausea. So the first couple of days after surgery, once I went out of ICU and then into the cardiology ward, where can only be described as completely miserable with those feelings of constant nausea. But I was only in the hospital for a week following the surgery. I mean, that's a real testament to the way in which, the medical world can treat you effectively. So by the time I got out, I had to stay with supervision for a week. So I stayed with my parents. I remember leaving the hospital, Mum walking me. There were people on walkers moving faster than I was down the hall. The feelings of exhaustion and lack of energy were palpable. The first day, I got up for breakfast, had breakfast, and had to go back to bed. I was exhausted. So those feelings of exhaustion I've never experienced in my life before. They're quite palpable. But, I remember rehabilitation. They would have programs for, eating right or giving up smoking, these sort of things. And one of the nurses said, look, we don't know what to do with you because you're doing all the right things, but clearly something's happened and it's not lifestyle related. And in a sense, that was the nub of the problem, because I was asking myself, well, what did happen here? And it was never really clearly explained. And I guess this is where FA comes in later with Travis. They said, well, you had very high cholesterol. But I was thinking, well, lots of people do, but they don't have a heart attack at 43. So that kind of would make sense later. But no one could clearly say, well, this is why it happened and so forth. So.
And just finally, Gavin, given everything that's gone on, the medication that you're on, and mind you, even with such a serious operation behind you, what's your outlook like for moving forward with your life?
Yeah, look, I think that one of the interesting things that happens with something like this is I guess you can call it a happy paradox. There's a side of me that has encountered death or the threat of death. And I've come to the conclusion that when you're touched by mortality, it does change your consciousness. And I'm convinced that unless you've experienced it, it's something that remains one step removed. It perhaps is a survival instinct of our minds that we sort of perhaps feel somehow that we're not going to die. We know it on a conceptual level, but at some deeper experiential sense, there's a disconnect there. An experience like this for me sort of bridges that disconnect very clearly. So it's something that I have had an experience of and carry with me at the same time. That doesn't necessarily have to be a macabre thing, but it just seems a deeper awareness and sensitivity. The flip side of that is a real sense for me that each and every day is a gift, because I do think to myself, had circumstances been different, that I would not be here, that I shouldn't be here. And that being here means, for me as a religious person, that there's some higher purpose, but just a sense of gratitude about each and every day because of this experience. And that has meant that I'm pursuing things in my life perhaps I would have been a little bit lackluster about, but now sort of say, no, don't waste time. The time that we're here on this earth isn't long, and we need to make best use of it and reach our potential. So I carry that with me, and I think it's a powerful way of living.
Well, that's wonderful. We've gone from Christianity and ended up with Stoicism.
Yeah, indeed. Oh, the Stoics got some things right. Yeah.
Exactly. Look, we are going to dive deeper into FH now in the rest of this episode, but for starting us off, thank you very much, Dr. Gavin Brown.
My pleasure.
We have a guest ready to join us, Associate Professor Damon Bell. Professor Bell completed his chemical pathology training and physician training in endocrinology at Wellington Hospital in New Zealand, and then gained his fellowship of the Faculty of Science of the Royal College of Pathologists of Australasia. He has expertise in acquired lipid disorders, hypertension, diabetes, cardiometabolic disorders, and metabolism. He's a physician, associate professor in the School of Medicine, University of Western Australia, and based at Royal Perth Hospital, and remains actively involved in research, having authored more than 85 formal peer-reviewed publications, and he's currently supervising master's and PhD students. Of particular interest for this episode, Professor Bell completed his PhD in familial hypercholesterolaemia. Damon, welcome to This Medical Life.
Thank you very much. Happy to be here.
I'd love to start with a question that has fed my curiosity since I knew you were joining us. You've done extensive research in this field, but can you tell us what attracted you to FH?
So I guess when I was going through my medical sort of training in the mid-90s, really, I was working with a physician, Professor Jim Mann, in the lipid disorders clinic at Otago University. And as a medical student, I guess I didn't have a lot of insight into the fact that I was at the pointy end of really what was occurring worldwide at that stage. So familial hypercholesterolemia has been known about for quite some time, but the sort of availability of treatments at that point, and then the knowledge around primary prevention was still coming into force. So we were doing lipid clinics before the WASCOP papers had sort of been presented, confirming the efficacy really of primary prevention of vascular disease in general. And of course, we were looking at familial hypercholesterolemia, predominantly heterozygous, but before genetic testing was really widely available as well at that stage. And so that's really what sort of got me interested in this. And in fact, in cardiometabolic medicine, before that term had come about, Professor Mann is a physician diabetologist, but also as the head of the nutrition department at Dunedin at Otago University. And so that was really what got me involved with it. And then it was also sort of knowing that, I was a decade out from Goldstein and Brown being awarded a Nobel Prize for their work with familial hypercholesterolemia and sort of discovering receptor-mediated endocytosis, something that we'd been taught in the early part of medical school as if it had been around forever. And so that was really the things that sort of showed me that there was a lot more we could uncover in medicine, and it got sort of set me on that path.
So what's our current understanding and knowledge of FH in this area? Can you bring us up to speed? What's important for us to know?
Well, I guess one of the things that has been important is about really understanding the prevalence of this condition. We used to think it was about 1 in 500 people. So actually, it's really between 1 in 250 and 1 in 300 people have heterozygous FH. So this is the most common autosomal dominant disorder in man. So that really putting that in perspective, it's as common as type 1 diabetes, which everyone would have learned about during medical school. Talking with people in the community, they will all be aware of type 1 diabetes and people with type 1 diabetes. Whereas you talk about familial hypercholesterolemia, and people have not heard of it at all, including, often, specialists and our primary care clinician colleagues. It's a condition where awareness worldwide is very poor, despite the prevalence, despite the fact we've now got really very, very good methods of detecting it. The genetic testing, we know there's 2,200 different pathogenic variants that we can identify. There's funded testing for that in Australia, which we're very lucky to have. And there's very, very good treatments and knowledge that early treatment is better, but yet the awareness is really one of the major limitations that we've got at this stage.
Damon, I'm really curious. Do you have any theories about that low level of awareness?
Yeah, one of the major things is that I guess everyone understands cholesterol as a vascular risk factor, but then it's also, there's been sort of perhaps, bad press or negative press around cholesterol, and people sort of do mix up the fact that some people with genetic disorders such as FH are very, very different than the background population. And there's been a sort of a move of saying, well, saturated fats may not be bad for you, which I don't really agree with. It's all about volume, and it's all about putting it in an individual perspective. So people with familial hypercholesterolemia, because they're not identified, and because there's all this sort of negativity around that, and that people are not being checked, people are not viewing the fact that if you've got a very high cholesterol, there may be a molecular cause for that rather than just a dietary cause. And I think the understanding of the pathophysiology around this is just, it hasn't really got through into the mainstream yet. And I think that's one of the major things that we've got a challenge for, because once you talk about it with people, with patients and with the other doctors, it makes such a lot of sense. But it really has been, it just hasn't been promoted and discussed enough. And so that's why I think podcasts like this is so important, because this can be, it really is a model for genomic medicine moving into the future. We can identify this predisposition for people, for a whole kindred. We can then treat people at a young age and remove this burden of vascular disease that has troubled their family for generations.
So, with regards to chemistry, some of the tests was one of the most common ones we come across are cholesterols, LDLs, HDL and triglycerides. But how do we sort of guide GPs into what's important for them to recognise, and maybe carriers or maybe people who will be affected? Is there a guide for us?
Yeah, look, I think that's a very good question, Travis. So when people are measuring cholesterol, they're encouraged to do it as part of really an absolute cardiovascular risk guideline, which I completely agree with. The problem is that for the people with FH, that 1 in 250 people, that is completely inappropriate. So we've now got levels that we put on where we suggest that these are the levels of cholesterol that you should have, an LDL less than 3 and a total cholesterol less than 5. But we actually don't give guidance to our clinician requesters as to where do these levels sort of fit. So if I ask people in the community, well, where do they think, if you've got an LDL cholesterol of 4.8, how high is that? And people don't really know. In fact, 4.8 is the 95th centile. The 99th centile in a population is 5.7 millimoles per litre. And by the time you've got an LDL cholesterol of 6.5, that's 1 in 400 people, the 99.75th percentile. So I think what we need to do, especially with my laboratory hat on, is, when people are getting cholesterol measured, we need to give very clear information about what this means, what the likelihood of familial hypercholesterolemia is. And because of the awareness, we actually need to explain, well, this is an autosomal dominant condition associated with an increased risk of premature vascular disease that's readily identifiable. There's molecular testing for it and fantastic treatments available. If we can put all that into a sort of interpretative comment, that's been shown to improve reductions of cholesterol and identification of people with FH. We just need to sort of get the message out there and have this more widespread view on, really the extremes of cholesterol.
Mm-hmm. Then can I ask about sort of clinical manifestations? Because I think that can be one of the clues as to why this is such a hard area, because, someone who's a carrier may not have any signs, but someone who's homozygous can have other signs. Is there any clinical manifestations you can tell us about?
Yeah. Look, so you've raised homozygous FH, and I think that's a condition which we should touch on briefly. So perhaps 1 in 300, 1 to 1 in 500,000 people have homozygous or usually compound heterozygous FH, where they've got 2 different variants, or they're usually different, they don't have to be, in the LDL receptor, ApoB or PCSK9. So that's a pretty rare condition if we're thinking round figures 1.5 million. So they get very marked tendon xanthomas, eruptive xanthomas, and xanthelasmas as well, which are cholesterol being deposited in tendons and under the skin. That these guys can actually have, cardiovascular disease, myocardial events, in their early teens. So it's a very, very aggressive condition that requires treatment, from very early age. So that is pretty rare, and I don't want to sort of confuse the message with heterozygous FH, which is a very common condition. So people can have some of these manifestations as well. One of them is called corneal arcus, which is a deposition of cholesterol in the decumbent membrane around the, around the iris. So we see that as a white arc or ring around the eye. If that's present before the age of 45, then that's quite suggestive of familial hypercholesterolemia. If it's present after that, then it's called arcus senilis, perhaps not a very charming term, but where it's more not so related to a cholesterol disorder. So that's something we can look for. Then there's also tendon xanthomas, which can occur in people with FH, heterozygous FH. They do take time. If we find them, then they're almost pathognomonic, apart from it could be cytosterolemia, but that's perhaps 1 in a million people, so it's quite rare. So those are the sort of features. One of the things that we need to keep slightly mindful of is because most people with FH, and there's about 100,000 people in Australia, and perhaps 90, maybe even 95,000 of them have not been identified yet. And so most of these people might be on a small amount of lipid-lowering therapy because they said, oh, your cholesterol's just a bit high, here's some lipid lowering. That would be enough for most people to actually resolve those tendon xanthomas. So the clinical manifestations from those sort of signs are becoming less frequent. But of course, premature vascular disease is something completely different. So if we think about premature vascular disease, which in an untreated male with heterozygous FH, 50% of males untreated would have had an event by the age of 55. And if we think about a woman untreated, 30% by the age of 60. So that's really something that we need to be mindful of. But sadly, our current detection levels for people with premature vascular disease in coronary care units is still very low. Coronary care, they come in, there are lots of other things that they're concentrating on, but the actual, potential for FH is being missed.
Can you tell us a little bit about, so let's say, about 5% of people have been detected. What's the effectiveness of early intervention in these individuals? Yeah,
very good question. So it is the lipid-lowering therapies, and when we're talking about predominantly initiating statin lipid-lowering therapy, so HMG-CoA reductase inhibitors, then the addition of ezetimibe, blocking the 9-6-1 receptor, but both of those have been proven to be effective. And then there's PCSK9 inhibitors, so monoclonal antibodies, which above their statin and ezetimibe can cause a further 50 to 70% lowering of LDL. So we've got tools out there that can take someone's LDL cholesterol from greater than 6.5, to less than 1.8 if we require. But if we think about that, so that would be put in place for someone with symptomatic multiple coronary artery disease, that's funded for that person. But if we think about this from a primary prevention perspective, the earlier that we get in with lipid-lowering therapy, the better. And so we're removing the excess burden of vascular disease by removing the cholesterol exposure to the artery walls, which is dependent both on time and also on the level of LDL cholesterol or level of ApoB containing lipoproteins. So if we think about that, there was a trial conducted by Professor Albert Wiegmann's group in the Amsterdam Medical Centre, where they followed children which he'd been treating with pravastatin for 20 years. Okay, so these children were put on to pravastatin because they were identified with familial hypercholesterolemia molecularly. And then he compared them to their unaffected sibling, because this is a dominant disorder, so 50% chance that, if one of the parents is affected, 50% chance that each of their children would be affected. when they were put onto pravastatin, now they achieved a 30% lowering, 32 I think, of LDL cholesterol in that group, and they basically removed the accelerated atherogenesis by looking at carotid intermedial thickness. So there was no difference there between those groups. They also looked at then comparing the child to the parent by the age of 39. So when they did that, and they looked at, how effective was it from a, removal of vascular disease per se. So there was 1% chance of a vascular event in the treated group versus a 26% chance in the parents. So phenomenal difference. And then when you look at death, 7% of the parents with FH had died by the age of 39, and none of the affected children because of the earlier therapy. So I think we've got very good evidence there for early effectiveness.
Okay, so then taking it to the GPs, what's important for the GP to know about FH?
I think it's, and not just for the GPs, right? The GP's got so many things to know about. But think for all doctors, including cardiologists, including vascular surgeons, including stroke physicians, that we all need to understand about familial hypercholesterolemia. But really the biggest point is awareness. So if people are aware of this condition, they understand that it's autosomal dominant, so therefore it's inherited. They also then understand that we've got funded testing for genetic testing for this, which has the benefit of obviously confirming the diagnosis, but it's got quite a lot of other benefits that I'm sure Graham will have talked about, that we can then identify these people, but not just stop there. This is a dominant disorder. We must perform cascade screening of the first and second degree family members, both children, brothers and sisters, parents, going up and then sort of find the whole kindred and offer them the ability to sort of have this primary prevention. That's really where the benefit's going to come from.
So then just moving our focus towards patients, what do you think it's important for patients to know about FH?
The same thing. I think, just to be aware that not all high cholesterol is caused by diet, that there are genetic disorders from this. If there is a strong family history of vascular disease or, especially cardiovascular disease in your family, to think about this. Go and ask your primary care clinician or GP, could this be FH? And then put it to them that, if the cholesterol is greater than 5 and you've got, a high, and you've had a vascular event, for instance, ask the question, ask the cardiologist, ask your GP, could I have FH? What are the implications that this has for my family? And it's equally so if you found out you've got an incredibly high LDL cholesterol, I think it's important for people to know about their LDL cholesterol. But if it's really high, say greater than 6.5, there's a very good chance that this is, if you've removed secondary causes, hypothyroidism, cholestatic liver disease, nephrotic syndrome, or steroids, that's going to have a molecular or genetic component to it. And it may well be monogenic FH. And so understanding sort of where these levels fit in for both patients and doctors is important. And patients with FH, I'm sure you can comment on it. There's a lot of information out there. There's good patient support groups, and they can really provide a lot of advocacy for further testing. And I think that's really, as I said, I think FH has the ability, because it's quite common, to be really the leader in genomic medicine in primary and secondary care.
Damon, you mentioned an important phrase before. You acknowledged how GPs have so much they need to be aware of.
Absolutely.
I am the layperson here on this podcast, and on their behalf, I'd like to ask, are there any tips or tricks for GPs that might not be in the textbooks about FH?
Yeah, so I think that is a good point. Keep it quite simple, I think that we need to think about people with an LDL cholesterol greater than 5 if they've got accelerated atherogenesis, be that cardiovascular or cerebrovascular or peripheral vascular, to think about, could this be familial hypercholesterolemia, or could it be another inherited condition such as elevated alpha-little a, but think about it from a could there be something outside of just the environment? Could it be genetic? If you've got an LDL cholesterol greater than 6.5, that is incredibly rare. Okay, 1 in 400 people or less, and you need to find a cause for that. If you can't identify it, that's a group of people that need to be sent to a specialist or a physician to think, what could this be? If they then diagnose FH, then to come back and to think about that in the context of that whole family who may well be under the primary care or GP care, and then they can say, okay, if they've been diagnosed, if the physician's undertaken genetic testing and found that variant, then the primary care clinician, if they're feeling comfortable, can order the genetic testing for the first and second degree family members. I mean, there's good support available. There's genetic counselling available as part of that process with Sonic. There's lots of different ways in which we can support the primary care clinician. But thinking about it for a start and then dialing a friend in some ways to start that is the way forward. There's great therapies for this, which, so PCSK9 inhibitors, which we briefly touched on. So these are monoclonal antibodies, the current ones available here are, that in Australia, that can really lower cholesterol hugely more than, or on top of statins and ezetimibe. So for these people, it's not about, oh, well, I can just put them on this medication. If we can find out what the cause is and then, get them onto these medication, we can remove that cholesterol burden hugely. And then those people moving forward, it's not that they get referred to a specialist and never come back. They get referred to a specialist, worked out, hopefully get one of these medications if they qualify for funding, and then they return back to a joint care, and the primary care clinicians can prescribe that moving forward. So this is a very, very prevalent condition where primary care are able to sort of be and need to be central to this whole process. What we must do is define that this is a treatable condition. So we're not talking about finding a rare, terrible neurological disorder that as yet we can diagnose but can't treat. This is a condition that we can treat. We can, if we find and identify these people early, we can remove the burden that variant gives. Okay, that is the key. This is something, you find it, you can treat it. You don't need to be concerned about it. It has removed that variant, that genetic sort of predisposition. It's gone. Mm. But I agree with you, Travis. It's hard, and so with my clinician's hat on, I spend quite a lot of time sitting down with the family. So I've just cascade screened Kindred remotely. It's what the parents had wanted. We had multiple conversations, and then I said, okay, in the school holidays, we're going to get together and sit down and then discuss all of these results together. It's you being aware of this as the parent, but it's also, we're now talking to kids that are, usually between the ages of 8 and 10, and saying, okay, this is cholesterol. This is the sort of things that happen. You've got to try and put it in terms of what that means to them, something they can understand, and then, why you'd want to be tested. The fact that if you are tested, you may end up being on a tablet. What is it going to do? And what that means in sort of child-friendly terms. And so I think that takes a lot of time. And I think that's one of the things that medicine really struggles for now, because often you've got such a limited time when you're with people, especially in primary care. Those guys, very time pressured. Mm. Whereas some of these decisions that, if you put enough time in for a start, then you've really educated the person that they've got FH. What does it mean to them? What do they want to do about it with the best knowledge that we've got at hand? And that's when the best decisions get made jointly.
No, that sounds great. Look, thank you again, Damon.
Associate Professor Damon Bell, thanks for joining This Medical Life.
My pleasure. Thank you for the invite.
Professor Graham Southers is the National Director of Genetics for Sonic Pathology Australia. He trained in clinical and laboratory genetics in Sydney, Adelaide and Oxford, and held senior appointments in the South Australian public sector before his appointment with Sonic. His current role involves the development of genetic services for patients and families across Sonic's clinical and laboratory services Australia-wide and he's joining us now on This Medical Life. Professor Graham Southers, welcome.
Thank you very much, Steve.
Where are we currently at when it comes to genetic testing for FH?
Steve, the short answer is we can do it well, and it's readily accessible. The problem is when we look at actually how effective that process is being, the uptake of this genetic test has been quite slow, and that is of concern. So we have, if you will, all the resources, the ingredients are there, sitting on the kitchen bench, ready to roll, but we're making only slow progress towards actually delivering the meal.
What's causing that slowness?
I think that there are two factors which might seem contradictory, but I think they're both at play. The first is that hypercholesterolemia is very common. About 1 in 10 people in the adults in the Australian community have a raised level of cholesterol, and that reflects our lifestyle, lack of exercise, the higher fat foods we eat, all those sorts of things. And it means that most doctors, patients and so on are very much focused on managing this tidal wave of hypercholesterolemia and seeking to control it to reduce the patient's risk of heart attack and stroke and similar. So the very familiarity of hypercholesterolemia is, in fact, I think, a potential blinding factor that they miss, and we all miss, a key part of the story. And the key part of the story is that FH constitutes a minority of the cases of familial hypercholesterolemia. So I can understand it not being the poster child for hypercholesterolemia. It's only a small part of the whole story. But the key thing is for those people who do have this particular type of hypercholesterolemia, it's a different beast entirely, and they need a different management approach and so on. So there's a lack of awareness and an over-familiarity about hypercholesterolemia. The two, in a sense, intersect to make people unaware, and I don't mean this in a pejorative sense, but almost in a sense uncaring about FH, because there are larger hypercholesterolemia issues to address.
So then can we look at this and say, well, how do GPs sort of tease apart who would be relevant to test for, or who's at risk? How do we sort of guide GPs in that process?
That's a really good question. How do we identify, or how does a GP identify the patients who need the sort of specialised testing that is now freely available? I know that it's freely available, it's Medicare rebated, so there is no cost barrier to getting this type of testing done. Let me just step back for a moment to say that there's no absolute black and white clinical sign that will tell you whether a patient does or does not have familial hypercholesterolemia. There is quite a large grey zone, and that does make it difficult. If you had a purist approach and wanted to identify every person with familial hypercholesterolemia in Australia, you would test everyone in Australia for the gene errors that can cause FH, and that would be very effective in the sense you'd identify every patient, but it'd also be horrifically expensive because there are so many people that don't. So we need to be in some triage tool, some screen to identify a subgroup of people who are at greater risk of having FH. And we'll have to accept that that screening tool is going to be imperfect. There'll be some people who will not be detected by the screening tool who do in fact have FH. So we're going to have to take a compromise here. And once we accept that there is a compromise, there are in fact some very useful screening elements that a GP can readily put into practice. And they centre basically around the level of cholesterol measured in the blood. Now, measuring the cholesterol level in the bloodstream is widely done on gazillions of people every year across Australia. And there are three key metrics that can be used as a threshold event to say we should do something about this. The first is if the patient has a total cholesterol either now or at any point in the past has had a total cholesterol of greater than 7.5 millimoles per litre, that's a red flag and requires further evaluation. Or if the patient has had an LDL, a low-density lipoprotein cholesterol, of greater than 6.5 at any point in the past, 6.5 millimoles per litre, that too is a red flag. And the third red flag is if they've had an LDL cholesterol level greater than 5 or greater than or equal to 5 millimoles per litre and have got some evidence of accelerated atherogenesis. So they may have evidence of some vascular compromise in the heart, peripheral limbs, whatever. If there's some evidence that of excess atherosclerosis happening, and that LDL cholesterol greater or equal to 5, that too is a red flag. Now, what to do with those red flags? Those red flags don't mean that this patient has FH, but if we were to test people who fulfill one or more of those criteria, about 1 in 3 would have a mutation. And so that's quite a good hit rate in genetics. And given the consequences of that in terms of better access to therapy, more appropriate targeting of those therapies and so on, this is actually really useful and important information for the patient. But I want to flag a second important role, which is particularly important for the GP, which is particularly important for picking up the people who would be missed by that screen. Remember I said that the triage tool is not going to be perfect. There is a really important role for the GP in picking up the people who have been missed, and it comes from what we call cascade testing. If you take one of the people, a person who has fulfilled one of those 3 criteria I mentioned about cholesterol levels, and they have been tested, and a mutation has been found, this is a familial disorder, hence the name. So it's really important that the first and second degree relatives of that person have a genetic test to determine whether they got this abnormal gene. Now, I say it's really important. It is from a medical point of view. That has to be framed in terms of patient consent and so on. But the key thing is that if there is a family member who has this abnormal gene, even if the cholesterol at the moment is fine, it's not going to be fine in the future. And so they need to have proactive treatment now, from the age of about 10 to 12 years. So this applies to children as well as adults. And the benefit of identifying these people who would otherwise slip through the net is that you can prevent the chance of them, or reduce the chance of them developing an early onset heart attack, stroke, sudden death in adulthood, young adulthood, 30s and 40s. And that is clearly tremendously important, but it does require early identification and early treatment.
So getting into the testing for genes, there's 4 genes that are currently tested by Sonic Genetics. So LDLR, APOB, I won't list the other ones, but are all genes or all mutations created equal? Are these all, just pathogenic? Is some worse than others, or does it not matter at this point in time? We're just wanting to identify them.
The genetic testing that Sonic provides for familial hypercholesterolemia involves a variety of genes and looks for a variety of mutations in those genes. Now, I'm going to talk about the 2 varieties separately because they carry different implications. So there are 4 genes that we examine, and 3 of these genes cause familial hypercholesterolemia, which runs, in a sense, vertically through the family. In genetic parlance, an autosomal dominant condition. So that if a person has a mutation in one of these 3 genes, they will develop familial hypercholesterolemia, and each of their first-degree relatives is at 50% risk of having the same mutation and of developing familial hypercholesterolemia themselves. The 4th gene causes autosomal recessive familial hypercholesterolemia, and this is where you need to have an abnormality, a mutation, in each copy of the gene. And your siblings are at 1 in 4 chance of having that same combination of mutations, but your parents and children are unlikely to be affected. So it's a very different pattern of inheritance. Although it's a different pattern of inheritance, the implications in terms of managing the risk of hypercholesterolemia, access to therapies and so on, is the same. It's just that the familial dimensions are quite different. So that distinction is one that we make very clear in our reports, and it's also an important part of the genetic counselling that should precede and follow this sort of testing. The second consideration is, what about the variety of genetic errors or mutations that we find in these genes? And this is a major issue for all genetics laboratories analysing essentially any type of gene, because there are millions of DNA differences between us. So Steve, you and I, if someone ran our genome sequence and tallied up the differences, there'd be something like 10 or 20 million differences in our genetic codes. And most of those differences would be of no consequence. They're just a little bit of noise, if you will, in the genetic code that don't carry any consequences at all. They're totally benign. Others would account for what, in a biological sense, are relatively minor differences, like your good looks and my striking red hair. No, it's not red hair. But no, there are cosmetic differences between us that will reflect genetic differences, and those are of no consequence. There will, however, be a tiny proportion of genetic differences which really do account for different risks of developing disease. And the challenge for a laboratory when it examines a gene is working out which of the differences that we might identify in the gene, including these genes that cause familial hypercholesterolemia, which of the differences are just noise and in fact don't explain anything, what are of minor consequence. They may result in some difference in how a gene and its protein behaves, but not going to be disease-causing. And what are the real humdingers that really cause disease? And so for every gene that we analyse, there is now an internationally agreed way of classifying these variants, and we are looking for the ones that are either definitely causing a problem or highly likely to cause a problem, and there is a quantitative metric that is applied to that so that there is consistency between the different laboratories.
Mm-hmm. So you did mention genetic counselling. What role do they play in testing for this and for tracing families?
With any medical test, it's important that the patient is aware what the purpose of a test might be and the implications for themselves. And that's an integral, it's almost an unspoken part of the care pathway that a patient goes down. But it's really important that we do explicitly recognise that for every test, not necessarily just genetic tests. It does become a particular issue with genetic tests for two reasons. The first is that with genetics, we are increasingly able to predict the medical future with a moderate degree or indeed a high degree of accuracy. So when we're doing a genetic test, we're not necessarily saying that you have a medical problem today, but we may be able to predict with a high degree of accuracy that you're likely, very likely to have a major medical problem in the future. And that's a different sort of framing or context for a test. And it's important that the patient is aware of those implications. The other consideration with the genetic test is that for some of these tests, and I've explained the differences of patterns of inheritance that we see for familial hypercholesterolemia, that there may be implications for other people in your family as a result of your test. And again, that's quite different from most other medical tests. So for these reasons, we place a more emphasis on the importance of pre-test information and counselling around genetic tests than for many other investigations. But I want to be very clear that those issues, I guess there's an increased focus in genetics, but it's not to say that those considerations only occur in genetics. They occur across all medical tests. Now, there are a number of ways that can be addressed. You could be the pre-test discussion, essentially the genetic counselling about these dimensions of the test, what its purpose is, likely outcome, implications, and so on. That can be managed by some doctors who are very confident in that and understand the dimensions of these issues, or it may be appropriate to bring into the story a genetic counsellor who is an accredited allied health professional. There's a very specific, a very good training program for genetic counsellors in Australia. It's a master's degree qualification with supervised experience and training. And genetic counsellors are available in the public and private sector around Australia. And the whole goal of that pre-test counselling, whoever is providing it, is to ensure that the patient can provide informed consent and there won't be any surprises, whatever the result. And once the result comes back, there is a place for genetic counselling to revisit whatever issues need to be revisited. And in particular, to talk about the importance of advising family members and encouraging family members to be tested as well. So, as I say, there are genetic counselling services in the public and private sector nationally. For this particular test, Sonic also offers genetic counselling as part of the process, because we recognise the importance of getting that right, that patients are fully aware of what's going on, and we want to reduce the barriers for patients accessing this type of testing.
Mm-hmm. And just finally, is there any tips and tricks that you can, suggest to GPs that might be useful in, with FH or with testing or with genetics? Is there any advice that you can give them moving forward for their assistance?
As I said at the outset, the real challenge with familial hypercholesterolemia is both the familiarity of hypercholesterolemia and the lack of familiarity with familial hypercholesterolemia. There, Steve, try saying that with another teacher. But there is this real double-edged challenge to how we approach this condition. I think for general practitioners, the first thing I would say is please be aware. This is a common condition. It's not as common as familial hypercholesterolemia, but about 1 in 250 people Australia-wide has a documentable mutation that causes familial hypercholesterolemia. So that's about 100,000 people in Australia, and less than 5% have currently been identified through conventional medical practices. So that there is a large cohort of people in Australia who have mutations, who would benefit from targeted therapies, who would benefit from specific therapy that is rebated by the PBS for this condition. Without that genetic diagnosis, they're going to have problems accessing that. So there are very real advantages here. And the GP need only stop and think, how many patients do I see through my practice in the course of a year? Divided by 250, and there on average, that's the number of people that you would have who should be being picked up. And the second step then, so first step is recognition. Second step is to use those cholesterol levels that I suggested. And in brief, an LDL cholesterol greater than or equal to 5 at any point in the past, or a total cholesterol greater than 7.5 at any point in the past, are sufficient triggers for you to reach for your Red Book guidance or whatever it might be to help you get with that. Now, one of the problems there is that I've said at any point in the past, because you may have a patient who's got familial hypercholesterolemia, who had a high level in the past and is now on treatment, which has brought the cholesterol down below those threshold levels, but not to the level which is really benefiting the patient. And we won't go into the technical details here. So there may be patients who, in a sense, are just sliding under the radar because they were already partly treated. And you're not going to recognize that because their cholesterol levels today would not exceed those thresholds. So I would encourage GPs to talk to their local pathology provider and say, can you do a search of all my patients in the last 5 years, whatever you like, who have had total cholesterols greater than 7.5 or LDL cholesterols greater than or equal to 5, and send me that list. And they will let your local pathology service do that bit of homework for you. And you can then prioritise those patients and review them in the way that we've discussed. We've also got more details on our website to help inform that process. But I think use your laboratory provider as an ally in this, rather than you feeling that you have to trawl around through years' worth of cholesterol records.
Wonderful. As always, I like how you've now heaped some work back to Dr. Travis Brown on behalf of the GPs he works with. That's great. But always you've raised just the esteem I have for the role GPs play at the coalface. Yeah, and also, absolutely, again, you and that wonderful insight into the genetics of so many aspects of our life. So, Professor Graham Southers, thank you for joining us on This Medical Life.
You're most welcome.
Well, that was quite a journey, and I hope as this episode gets shared around, there's a raising of awareness of FH in Australia and beyond.
Look, it's been a confronting. This was an episode I put off for a while. I sort of knew it was important, but it's a challenge. Like going all the way back to the start. Where Gavin says, family history. When you look at our family history from a sort of a medical perspective, you actually wouldn't think it initially. And that's the thing, our grandparents lived into their, 70s and 80s, wasn't, heart attacks. We haven't got this really strong family history of, no uncle making it to, the age of, 50 or something like that. We do have a, history. One of our uncles on my mum's side had a, early heart attack in their 40s. But you explain that away because, heavy smoker and, everything. But aside from that, Dad had an angiogram, around 50s, and yeah, he needed statins, but it wasn't as strong as what you would think for this kind of a condition. And that's surprised us.
So as you were doing these interviews, now that we spoke with Gavin at the beginning, your brother, are you thinking deeply about yourself? Are you a candidate for FH?
Yeah, no, I've been tested and I'm positive. So I have the LDLR gene. We've always known, and here's the thing, where we early in my 20s, we ended up having some blood tests for some reason. My cholesterol through the roof. I was just like, that's odd, unusual. And again, like Gavin, I looked after myself. I didn't, really drink. I sort of don't smoke or anything, never smoked. And so I remember, the GPs at the time going, well, that's an unusual result, but we don't have any other risk factors. And I'm sitting there going, well, do you treat it? Do you not? And I think we started initially treating it to try and bring it down a bit. And from there, it was like, well, I never took it too seriously because I'm going, well, it's just one risk factor. Smoking's a much stronger risk factor. And that's been sort of on and off for 10, 15 years. And then this event happened to Gavin and that, changed things significantly. And so that was the process. I think the hardest thing for me, like when it's yourself, it's like, okay, well, I need to do this, I want to avoid. The hardest thing for me is I've tested positive, so then family tracing testing happening, and that's ongoing at the moment. The hardest thing for me was acknowledging I needed to get my children tested. 2 boys aged 9 and 10, so, and it's pretty much believed that, when you've got children about the age of 10, you should test for this because that's when you can start either managing or treating the condition if they have it. And I think that was the hardest thing for me we've just had them tested, so, waiting results. But it took me, I knew about this in May, and it's taken me about 6 months to
right, to acclimatize yourself and process the information.
Yeah, well, it's really weird, but I'm having to my own mortality, I understand, we grew up in a religious household and, you come to terms with what you understand and believe in that. But I had to sort of face the mortality of my children. And that for me was confronting. You had to sort of accept that, this is a condition. Now, Damon was saying this is a really treatable disease. But at the same point in time, you sit there and just go, yeah, but it's still a disease. So I just, yes, it's something we can actually do things about, and we'll get there.
Final thought for GPs listening: when you end up being diagnosed as something that you diagnose other people with, what are you taught in medical school on how to not suddenly see that in everyone or just not go off into a spiral?
I think what Professor Bell and Professor Suthers have both indicated is just thinking of it, to be honest, is probably the most important point. This patient sitting across from me, could they have it? And if it's if it's just a simple screening test for cholesterol, that's almost the point where you're looking at it and saying this is a consideration. Now, if you choose that they're tested or, their treatment, imagine if we're actually able to find some families who do have it, who we didn't suspect have had it. We can actually change not only that person, maybe hopefully prevent them having a heart attack, but their children, their family. And that's the impact that this will have.
Well dodged. What I asked was, what about when you end up having to diagnose yourself? Is there any training to help with that?
No. And it will be a personal, experience. Some people will manage it really well. Some people will probably have even confronted it before they studied. And some people might actually study because they've had to confront it. It will be a personal, some people will be fantastic and some people will be terrible. I've found my experience when I'm dealing with my own children, I am a terrible doctor and probably a debilitated dad. But fortunately, my wife is actually fantastic at dealing with all of that, so it works out well.
All right. Well, thanks for that personal journey you've taken us on, Dr. Travis Brown, as we've looked into, I'm going to try and say it to finish off the episode, familial hypercholesterolaemia.
Excellent.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Life is uncertain. It's okay to feel stressed, anxious, worried, or frustrated. CalHope can help. Access CalHope's free and secure mental health resources. Call 833-317-4673 or live chat at calhope.org.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.